Blood Talk fams. Last week we talked about cross-match, and one of the steps that I mentioned there is to check for special needs. So, today's video, I will talk about what is considered special needs in blood bank and why the patients would benefit from that special product type. Okay, without further ado, let's get into it. First product that we are going to be talking about is irradiations. We irradiate blood products to prevent proliferations of T lymphocytes, which helps prevent transfusion reactions associated with graft-versus-host disease. Basically, the irradiations will kill the viable white blood cells that are left in the blood products. We do that by irradiating the products with gamma irradiations. Before we load the blood back into an irradiator, we put an indicator on each unit. This indicator will turn black when it's exposed to a proper amount of irradiations. Who should we give irradiation blood products to? High-risk groups are fetal and neonate recipients of intrauterine transfusions, the components that come from a blood relative, cancer patients, bone marrow transplant patients, organ transplant patients, and recipients of cellular components whose donor is selected for HLA compatibility. What are the side effects? The irradiations damage the red blood cells membrane, so units of irradiated red blood cells have shown to have a higher potassium level than a non-irradiated blood units. Because of this, when a unit has been irradiated, the unit will have a new expiration date of 28 days from the collection date or the original expiration date, whichever comes first. There's no known side effects for irradiated platelets because nowadays, the method we use to collect platelets has minimum number of red blood cells in there. The expirations do not change for platelet. The platelets already have a very short shelf life. I did not mention about plasma because usually we do not irradiate plasma. Since the plasma was previously frozen and thawed out before use, when the plasma was frozen, the white blood cell lies, so there's no need for irradiations. However, plasma that's come from a whole blood and never be frozen may need to be irradiated to prevent graft-versus-host disease. Second product type that we will be talking about is wash products. Why do we wash ourselves? Washing removes unwanted plasma proteins, including antibodies, and remove glycerols from previously frozen units. The downside of this is that there will be some red blood cells lost during the washing process. The platelet can also get activated during the washing process, which leads to loss of platelet. The shelf life of wash components is no more than 24 hours at 1 to 6 degrees Celsius or 4 hours at 20 to 24 Celsius. Washing is not a substitute for leukocyte reductions, and only cellular components should be washed. Who should be receiving wash products? Washing may be used to reduce exposure to plasma protein, cellular components, or additives such as mannitol. This is to reduce exposure to antibodies targeting known recipients' antigens. Washing is also remove IgA containing plasma involving transfusion supporting for an IgA deficiency recipients. Third product that we are going to be talking about is antigen-negative red blood cells. Antigen-negative products is required when the patient has antibody. The antibody could be the one that we just identified or previously identified. Once an antibody has been identified, the requirements stay there forever and become requirements for subsequent transfusions. We do not ignore the history of antibodies even if it's not currently identified, because antibody could be below detectable range, but the body will ramp up the antibody productions as soon as the antigen is introduced. Lastly, I would like to touch on leukocyte reductions and CMV blood products a little. Leukocyte reduction is no longer considered that special anymore. It is not because it's not important, but because donation center do the leukocyte reductions before storage. So before the blood has been shipped to the hospitals, it's already been leukocyte reduced. So pre-storage leukocyte reduced platelet and red blood cells are considered to be CMV-reduced risk. Leukocyte reductions products considered to be CMV-reduced risk. This means it can be used for patients with CMV-negative requirements when CMV-negative products is not available, but yet you have to put a claim on the back that it is not CMV-negative. In short, leukocyte reductions is not the same as CMV-negative products, but can be used in place when there's no CMV-negative available. For our units to be considered CMV-negative, the donor must have a negative CMV antigen test. Who is required CMV-negative units? It is the patient whose results is CMV-negative. Who should be receiving leukocyte reductions, red blood cells or platelet, leukemia or lymphoma patients, transplant patients, or a history of febrile transfusion reactions. If these requirements do not confuse you, then keep in mind that a patient could have more than one requirement. This frequently happens with patients who have a history of multiple transfusions, such as sickle cell patients. Thank you for staying with me until the end. What do you want to know next? Do you want to know more about blood bank, chemistry, or microbiology? If you have any burning questions, please feel free to leave me a comment down below. Lastly, if you have not done so, please like, share, subscribe, and click that notification bell. I will see you in the next episode of Blood Talks. And as always, remember, your blood tells you the story of your health. Thanks for watching. Bye!